My topic is pretty much a start of plenty of longitudinal research to look into joint health based on gender differences or biological sex. So this was a start after 2 years of work, which is probably not much for most of the researchers in the realm. I looked for years of practice in the primary care for how we manage soft tissue disorders or joint health in general. And I found that we do tend to pretty much give the same prescription to everyone, regardless of where they fall in their professional life, how they live their occupation, what kind of reproductive phase they're on, and definitely biological sex does not seem to play an impact much in our role. And primary care physicians, we do tend to be the frontliners at the forefront of encountering most of these soft tissue problems. And I could not really find much guides on how to approach it depending on individualized determinants of health or tailoring it to my patients, specifically females. A little bit of background about myself. I started pretty much within family and community medicine training. I had an extensive public health education background. I talked to the community. I did a lot of community outreach in non-for-profit organizations, and I found that people hear things differently from the way we say them. And they tend to perceive guidelines and clinical approach as too complicated for day-to-day implementation or application. And I think we kind of evolved over time by developing what we call clinical translational research and then patient-centered outcome research. And then now, like, the way I look at how I provide healthcare is more through a framework. What do we do as a community, and what kind of environmental factors can make a difference in an individual life? And then my professional focus started to be more in the women's health as a population to figure out if I can identify biological differences, since I know certainly that my experience of health is different from my male partner. So I kind of looked at what's the impact or the burden of having a joint health. And I found that in most primary care settings, there is more than 12% on a daily basis of our encounters are purely musculoskeletal issues. And then I came to learn over the years that the low back pain specifically, to be more focused, since this is how we like to approach research methodology, is the highest on top of 293 diseases. So it has the highest global burden of disease, according to the CDC, until 2019. And I don't necessarily see that changing. And especially for Americans, I don't know if our audience are from different parts of the world, but in the United States, we don't move a lot, we kind of tend to live sedentary life. We drive like we spend 1/3 of our lifetime pretty much driving, which is an asymmetrical movement and pretty much sedentary. Personally, I have no potential conflicts or disclaimers, any conflicts that to kind of disclose, but I'm certainly a strong advocate for women's health. So hopefully that is a shameless bias that I will continue to carry. The low back pain continues to be the fifth reason for office visits. It can recur up to 80%. So it is pretty much chronic medical condition in nature, at least up to this moment. The current approach is not really individualized based in general, but the focus of the study was to look at biological sex impact. Women do tend to have lower threshold to develop the low back, but then higher threshold to seek help. So they're always delayed in approaching medical care. There are identified hormonal factors, specifically in the low back pain, due to the involvement on the pelvic anatomy. Pelvic dysfunction, of which you can call bladder incontinence, constipation, menstrual dysfunction, endometriosis, you name it. Our pelvis is very special in how it experiences health from phase to phase, prior to puberty, crossing puberty, going through reproductive function of childbearing, breastfeeding, carrying baby on one side, favoring one side over the other, and then menopause afterwards. And most of the time, our pelvis is pretty much invaded throughout the reproductive age group through pelvic examination, pap testing, endometrial biopsies, and so on. The question that I had in my mind, do we as providers see biological sex when we are treating joint health? Do we see that biological factors based on gender is actually making a difference? So is the difference in women experiencing joint health a perceived one or a factual one that is established in research and scientifically, starting from the cell level up to the environmental circle? Hormonal profile, gender role, lifestyle changes. As you can see, we are, most of the time, if you were to find a high heel shoes, it's going to be marketed and commercialized to women. If pregnancy was to happen, and I'm not talking about the android belly like that we gain over time after menopause. I'm talking just about childbearing, where the center and the focus of the body changes from women to women. And how many of us actually get the adequate health education to make a difference in how we perceive or how we preserve joint health over time. So the objective was just to explore how we primary care providers tend to experience and practice our approach to low back pain in females in general. And I compared that to males in the United States specifically. Of course, it's an unfunded research, so it was really difficult to kind of have a wonderful response rate or even have funding enough to have an epidemiologist work with us on a survey tool. So hopefully that this study will be like an opening to longitudinal studies with more validated tools now that I have more support and a bigger research team to work on that. It was pretty much a cross-sectional survey-based study, approached my own department at the Ohio State University at that time. Then I approached my circle of primary care providers through the AFP. It was pretty much convenience sampling, so it's sent to the people or the department list that I had access to, which was anonymous, so we were not able to identify who provided an answer or not. I created a 27-item online survey. Some of these questions were pretty much demographics. I had to look at how to best ask questions to identify if where the provider is coming from, their race, their ethnicity, their age, their expertise, clinical focus, would that impact their patterns? And then all of these things were pretty much from my personal experience. And I think that's sometimes makes it hard for academicians like myself to approach the scientific or research community by my own experience, which I strongly believe that if I'm going to do a research, I want to do a research in a field that I work in, that I have hands-on in. So luckily we had 58 responses from what we would call 232 email addresses that we had on our listserv. I had a great help from a wonderful analyst, Dr. Amanda Start. She's a great research partner. Kudos and great greetings to her. She's probably currently sleeping in Ohio. We did literature review, which I really could not find any similar studies in the United States. Luckily, I found the same question that seems to cross minds of researchers in Europe, even though it's like a more active community. Some of those were based in the Middle East as well. So I couldn't necessarily find the same research question looking at what we do as providers to improve the global burden of that specific disease. Our respondents answered, yes, I had a low back pain in 9 out of 10 of the cases. So pretty much 90% of our cohort, the 58 respondents, had experienced low back pain at least once in their lifetime, which pretty much mirrors what is in the literature of the commonality or how common or pervasive this disease is. PCPs or primary care providers were not in agreement that low back pain is different in women than men. And I think that per se for me was extremely validating, but not necessarily consoling. Clinicians with women's health, osteopathic, or sports medicine background were more likely to agree that low back pain is experienced or is different in women than in men. This is an interesting chart. We didn't ask about contraception or gynecological history in males and females, but we did ask if our providers do ask about occupation. Do they ask about like how chronic the medical condition was and the impact of home tours, so the gender role, and are they more likely to schedule a follow-up? And we found that there is actually some differences between male and female patients. When we approach them as primary care provider, we're more likely to counsel female patients towards the gender role home tour based than we were to counsel male patients. And then we're more likely to kind of discuss pelvic floor exercises with females than we were to prescribe those to male patients. But when we do intake, so when I am gathering data or history from my female patients, I don't necessarily ask them about pelvic symptoms. Is there any pain during sex? Is there any bladder symptoms? Are there any problems controlling your bowel movements? And so I tend to think we tend to want women to remain functional pelvic wise, but we don't seem to attend as much if there were pelvic symptoms or not. And we do have that gender role bias, so we do tend to perceive that women are more likely to do home tours than their male partners will be doing it. From my standpoint, I kind of interpreted that in my discussion as a knowledge gap amongst primary care providers towards the impact of biological sex on low back pain. My suggestion and my recommendations based on these findings only in this study is just to introduce the idea that females experience that specific disease a little bit differently, which means your history gathering should be different at the forefront of that illness. Your interest in scheduling follow-up, knowing in the back of your mind that women have low thresholds, so they're more likely to develop the low back pain, to schedule them for follow-up, since they are also more likely to delay their medical help seeking. And then I think there's a lot of further investigation that I would like to do. One, I really want to know if patients also agree that they do experience low back pain differently, regardless of their sexual orientation or gender identity, just biological XX chromosome. Do you experience low back pain in a different manner? And the low back pain choice was not just because I believe that's the only joint health that we experience differently as females, but also just to be more specific in my approach and in my questions and validate the tools, since surveys are kind of tricky in the way we do research. So I'm hoping that the survey that has been offered in this study will be fine-tuned in the future, that I'll be able to expand the reach to more of the United States primary care providers. So I'm hoping to kind of run a national surveillance through utilization of all kind of primary care associations like AFB, AMA, ABIM. So more like focus pretty much on the national field for now, since it doesn't look like an area that we have attended to compared to Europe and the Middle East. I'd like also as an academician and an educator to focus on bridging that gap. As we know, like I'm not going to wait until I know a lot of information, but I want to introduce that into medical education curriculum and more on the medical student level, actually, before they choose their specialties, so they have that at the back of their mind when they are approaching females in general. And then I'm hoping that a qualitative study of female patients' experiences regarding the low back pain and how we can improve the presence of guidelines, since there isn't any. In the AFB, we tend to do the AFB, which is the American Academy of Family Physicians. We do tend to do great in providing algorithms of how to approach certain common problems or common diseases that are there at the forefront in the primary care offices or outpatient settings. So my hopes is to introduce some sort of an algorithm of, if you experience low back pain, is it a male, is it a female, and how to approach each one of those specifically when you are prescribing medications. So, and also lifestyle prescription. These are some of my references, and thank you so much for listening. Looking forward to